session. Just reminding members, please switch off all mobile phones and devices as they will interfere with the recording equipment. A number of items under Chair's business. First of all, just to advise members that the motion to extend the committee stage of the Control of Data Processing Bill is on the order paper for the 21st of September, and I will speak to the motion. Also seeking agreement to write to the Department for an update on a number of issues given the current gap in terms of the Minister in position. Firstly being the progress in relation to the production of the commissioning plan. We're told that the commissioning plan, the draft, hasn't been completed. The Department's response to the Donaldson plan. And thirdly, the investment and development in the Children's Heart Centre in Belfast, coming from the proposals around the Dublin-Belfast hub and spoke model. I also think it would be important, given the scenario that faces us, that we ask officials to outline how, in the absence of the Minister, how these key issues, along with other key issues, would be taken forward. I would add to that for an update on the issue of the pay review body's recommendations on the 1% pay increase for nursing staff and other medical staff, for a direct update from the Department as to how that's going to be implemented. Are members in agreement that we would do that? Yes, Rosie, and then Farrell. Are you okay? I thought you had indicated. No. No. Okay, sorry.
No, Chair. I know that I put on record on the Assembly floor yesterday our party's disappointment, if not dismay, that the Minister has actually resigned his position, and you've outlined there a number of issues that should be furthered and could be furthered if the Minister remained in his place. But there are other bigger issues there. There's 300,000 or in excess of 300,000 people looking for outpatient appointments. There's huge queues around elective care. There are major issues of public concern that can only be addressed through a Minister being at his desk, and I want to put on record in this committee our party's disappointment and dismay that in fact he's not in his seat.
Okay, thank you. Danny.
Thanks, Chair. I agree entirely with what you're proposing, but I think we need to ensure it's comprehensive as well. I think when the DRD Minister tendered his resignation, there was a number of examples. I think there were some decisions in Mid-Ulster, I think it was pertaining to speed limits, that were held up as a direct result. So given the size of health, I'm sure there's numerous decisions that are awaiting sign-off that are going to be delayed by a number of weeks. I think we need to see what all of those are, because all of them, I'm sure, are quite important to the people who represent.
Okay, thank you.
Thank you, Madam Chairman, and I agree with what you've proposed in terms of getting a briefing around these issues. I think that's important for the committee to do that. Not to rehearse how we've got to this point, but it's certainly not what we would have wanted, but nevertheless others chose not to work with us in terms of adjourning the Assembly, and therefore steps have had to be taken to focus minds, and I trust that we'll be able to work through those issues, and we will then have the Health Minister back in place. If we can't work through them, we'll not need to worry about this committee because there won't be any Minister in place. So I trust that we can get a resolution to these things.
Okay, points are well made. Thank you.
Chair,
George, yes.
Just agree entirely with Paul has said. There's so much hypocrisy at the present time. It's absolutely scandalous. People know exactly what's happening, why we're in the situation that we're in, and everything that Paul has said, that I entirely agreed with him.
Okay, so we're seeking a robust progress report as to how these key issues within health are actually, first of all, being identified and being progressed, given the fact that we are in a scenario that we don't have somebody making decisions currently.
Great.
Thank you. Members, item 4 is the Forward Work Programme, page 29 for the relevant papers. Just to advise yourselves that the committee had an initial discussion at the strategic planning meeting last week on our approach to handling the legislative workload. Members had expressed a preference for prioritising the bills in terms of the order in which we deal with them. So in order to do this, we will need more information. The point was made in our planning discussion. We need more information in terms of the content of the bills and their aims and objectives in order to make an informed decision on how we prioritise. Therefore, there have been briefings organised for the 23rd of September on the 2 departmental bills, and we have also asked Ms Dobson to come forward on the 30th of September to brief the committee on the private members' bill on human transplantation. We will then hold a further strategic planning meeting on the 30th of September at 4 o'clock after the formal meeting has ended to discuss our approach then to the legislation from an informed position. So in the meantime, there are issues that need to be considered, specifically in relation to the human transplantation bill, which is to be introduced on the 21st of September to the House. So I'm going to ask the clerk at this point to just brief the committee around the current scenario around the human transplantation bill.
Okay, thank you, Chair. In terms of the time available to the committee to scrutinise any bill that may come to it, members know there's tight time constraints in place. The latest date which would be prudent for the committee to report on any bill is the 20th of January if it wishes to maximise the chances of the bill completing the remainder of its stages. So working backwards from that, this means that the latest date for an informal clause-by-clause deliberation would be the 9th of December. To be able to do an informal clause-by-clause deliberation, a committee has to have considered all the evidence received from stakeholders, have completed its negotiations with, in this case it would be with the bill sponsor, and have any sight of departmental bill sponsor or committee amendments. So all of that would need to be done by the 9th of December if you were going to report on the 20th of January. A committee stage begins with a committee issuing a call for written evidence on the bill and providing stakeholders with it's normally a 4-week period to respond. If the committee were to do this in relation to the human transplantation bill pending a successful second stage, it's likely that the call for evidence would issue around the 20th of October with a 4-week deadline of the 17th of November. This would leave the committee very little time to consider written submissions and take oral evidence based on those submissions if it wanted to complete all its deliberations by the 9th of December. So there is a precedent for issuing the call for evidence once the bill has been introduced, rather than waiting for it to pass second stage and formally commence committee stage. It was done most recently in relation to the mental capacity bill, and the reason was because of the time pressure, because that bill is so large and had been introduced at a relatively late stage of the mandate, and this allowed for the written submissions to be received earlier and to be analysed and witnesses selected over the summer recess. However, I would point out with the mental capacity bill, the Assembly had already agreed to establish the ad hoc committee to scrutinise it before the bill was even introduced, so this did give a clear indication that the bill was very likely to pass second stage. There's a table at page 32 of your packs outlining 2 alternative draft timetables for completion of the committee stage if the committee decided to select the human transplantation bill as a priority and to report on it by the 20th of January. One timetable is based on issuing the call for written evidence immediately following introduction, which, as Chair said, is next week on the 21st, and the other is based on the committee issuing the call for written evidence at the beginning of committee stage. There are advantages and disadvantages with each approach. So if the committee issued the call for evidence immediately after introduction, this would allow more time for written submissions to be analysed and witnesses to be selected on the basis of those submissions. In contrast, if the committee issues the call at the commencement of committee stage, this will leave it in a position of having to select witnesses for oral evidence without having a clear view of the issues that are going to be contained in the written submissions. However, turning to the other side of it, there are risks associated with issuing a call for evidence immediately following introduction and therefore before the bill has passed second stage. the public notice would have to be very carefully worded to ensure that stakeholders understood that written evidence was being sought on a without prejudice basis, and that if the bill didn't pass second stage and therefore come to the committee, stakeholders' evidence wouldn't be progressed by the committee.
Okay, thank you, Catherine, for that. So we really need to seek views at this point on whether the committee would wish to either issue a call for evidence following the introduction of the bill next week, or issue a call for evidence at the beginning of the committee stage, obviously dependent on successful passage through second stage, or discuss the matter further at our strategic planning meeting on 30th of September once the briefing on the bill has been received, or if there are other options. So, can I say from my own point of view, I think it's difficult, let's say, to issue a call for evidence at the introduction stage when we haven't had a brief ourselves as a committee of what the bill will look like or the content of the bill. So that's my instinct, that call for evidence will be premature at the introduction stage, as we won't have the briefing from Ms Dobson until the 30th of September. But open to other members' comments or thoughts on it. Yeah.
I think I tend to agree with you. I think it would be premature when we don't have really any detail at this stage. I think it would be premature to be looking for calling for the evidence before we have any further detail.
Alex?
Yeah, just the same view, to be honest with you.
Okay, Kieran?
I mean, I hear what you say, but I mean, it is important that we try and move things forward as quickly as possible. You know, the other alternative is, Catherine, what did you say? To take evidence as early as possible, or at what the next stage? I mean, it's to try and move it forward.
Yeah, but it would seem to be that what we're suggesting here is that it would be premature to call for evidence at the introduction because we don't know the content of the bill. Then one of the options is that we call for evidence at the beginning of the committee stage, or we discuss the matter further at our planning meeting on the 30th of September. And all of those are complex in their own right because of timelines.
Sure.
What would members' preference be?
Next,
Discuss further in the 30th.
Discuss further in the 30th. What are the implications of that? Does Catherine want to just maybe outline us in terms of timescale?
Well, timescales are that, I mean, if the committee decided at that stage, well, that's an informal discussion, it would have to be formally ratified at the next meeting on the 7th of October, that it was, let's say it wished to go out with a call for evidence, that could, you know, realistically go out then the 8th or 9th of October. The other alternative, the committee decided that it wanted to wait until the bill actually started at committee stage. That would bring you probably till about the 20th of October. So you're talking about probably a 10-day difference.
But to discuss further on the 30th still leaves us within a credible time frame.
Well, I suppose, Chair, just point out, I mean, the issues around timelines and extensions would need to be discussed further. It is still an extremely tight, you know, time scale.
Okay, but what I'm hearing here is discuss further on the 30th.
Yeah.
At this juncture. Okay. Okay, members. Thank you. Item 5 then is the draft minutes from the 9th of September, which are page 43. Are members content with the minutes?
Great.
Okay, and moving on to item 6, which is Health and Social Care Control of Data Processing Bill, and it's a briefing by the Human Rights Commission. Just advising members, representatives of the Human Rights Commission are here today to give oral evidence on the Health and Social Care Control of Data Processing Bill. There's written evidence that have been submitted by the Commission, can be found on pages 50 to 61 of your meeting pack. There's a summary of responses to the committee's request for evidence, which is also at page 62, and the department's response to the summary is still outstanding. So you're very welcome. Folks, we have Les Almby, Chief Commissioner, David Russell, Deputy Director, and Fiona O'Connell, Researcher. So we're just going to invite yourself to make an opening presentation, and we will open it up to comments or questions.
Thank you and good afternoon. And I intend to make a very short statement and then happy to take Q&A from Chair you and your colleagues. The purpose of the bill is to allow the Department and other bodies to utilise health and social care information which identifies individuals, and that's for the purpose of furthering the interests of improving health and social care or to meet the public interest. The bill also sets out that there will be a regulatory framework, although most of the fine detail of that will be set out in regulations. The explanatory memorandum to the bill is very open about the policy objective behind this, namely to minimise the risk of legal challenge facing the Department and health and social care bodies where individuals are readily identifiable from the use of secondary data for research or other purposes. I think our starting point at the Commission is we recognise the value of the policy premise behind the bill, namely that secondary data, in other words, information beyond the direct care of the individual, can have genuine value for research, policy planning, and ultimately delivery of health and social care services, as well as for other services where the aim, if you like, is to promote the societal good. There's currently a common law duty of confidentiality, common law based on court judgments, and there are three circumstances in common law where the issue of disclosure is allowed. First, where consent has been freely and genuinely given. Second, where there is a statutory basis which either allows or requires such a disclosure. And then thirdly, where the balance of public and private interest favours disclosure. The first two of those are relatively straightforward. It's the third one that has traditionally been much more complex, and deciding what is the balance of public and private interest, and making that balance when you decide those decisions. You may reach a decision that the courts ultimately decide is different. And the worry, I suppose, about the courts entering this domain has had a potentially chilling impact about making the best use of secondary data. So the bill will override the common law duty and replace it with this new statutory provision. Among the issues that we looked at within the Commission was the use of the data for the purposes of public interest. Public interest is extremely widely drawn. It clearly stretches beyond health and social care. And initially, I think, and in our submission, we suggested that it might be more narrowly defined, for example, to cover health and social care and public safety. There is a downside to doing that, in that if you narrow the scope of the use of secondary data to public safety as well as health and social care, there may be other legitimate purposes that you would use the data for that, again, you're back into the common law duty. I think on reflection, there is an alternative approach, which would be to leave public interest as it is in the bill, but to ensure that the safeguards are robust enough so that, for example, you could ensure that in the Code of Practice, the factors that need to be considered when assessing what the public interest is could be articulated very clearly. You could, and I'll come back to this briefly, make the Code of Practice something that must be followed rather than merely have regard to. There is some recent case law within the European Court of Human Rights on this issue, a case called LH versus Latvia, where judgment was given in July 2014, where the court held that the lack of precision in domestic law in Latvia, allowing public authorities to collect medical data, was actually a violation of Article 8, the right to respect for private life. And there was a very useful, and it's in our submission, but short paragraph that I think crystallises very clearly and neatly the issues and that illustrate the value of this bill. What the court said was that it reiterated that the protection of personal data, particularly medical data, is of fundamental importance to a person's enjoyment of his or her right to respect for private and family life as guaranteed by Article 8. Respecting the confidentiality of health data is a vital principle in the legal systems of all contracting parties to the Convention. It's crucial not only to respect the sense of privacy of a patient, but also to preserve his or her confidence in the medical profession and in the health services in general. The domestic law must afford appropriate safeguards to prevent any such communication or disclosure of personal health data as may be inconsistent with the guarantees in Article 8 of the Convention. And it seems to me that this bill, by providing and codifying in law the situation and providing a number of safeguards, would deal with a number of the concerns that were raised in the Latvian case. So, on that basis, first of all, we welcome the setting up of the committee. We think it should either be a requirement, although I have no reason to doubt that the department intends to set up the committee, or perhaps in the alternative it would be useful if the committee would just ascertain a timetable for how long the department intends to take to set up the committee. And I think the second area that we think might be worth exploring, which is to be dealt with in regulations, where it says that regulations may be made in order to deal with reporting and publication. I think it would be important to clarify exactly what that reporting and publication of the authorisations they have in mind. I don't know whether that's an annual report that would come to the Assembly or something else, but I think it would be worth at this stage clarifying what the department's thoughts are on that issue. The second issue that we raised just on the committee is the importance of being mindful of the diversity issues in terms of the committee. And I'm thinking here, including on ensuring that people with experience of disability issues, both first-hand and other knowledge, gender and cultural issues, I think will all be important in terms of some of the areas where the data may be valuable and useful and mined for other purposes. It's important to have people who have been at the sharp end of those experiences involved in this. And I can imagine there are diseases and illnesses that are much more gender specific in some cases than others, and therefore I think it's an opportunity to deal with that. And I think again it would be helpful to ascertain from the department how they would ensure that's done in practice. And then secondly, the code of practice itself. It must be prepared as soon as reasonably practicable and then published. I'm not sure what as soon as reasonably practicable means in practice, and again I think it would be very helpful to ask the department for a timetable both for the committee and for other interested parties to get a sense of how long that might take. We also think it would probably be valuable to have the code of practice, rather than that health and social care bodies must have regard to it, but perhaps to strengthen it by saying that it must be complied with, and in particular that it should address the specific Article 8 safeguards. There's some interesting case law in public law terms around the question of guidance and circulars and whether they are binding on public authorities or not. And it often depends on the language and how it's framed and used. And courts have taken different views on different types of guidance. But we think it would probably be better to have the certainty of saying that the code of practice, which is very important, it seems to me, for this particular piece of legislation, should actually be complied with, and that way it would put it beyond peradventure. So that's, I think, our short and relatively sweet comments on this. We think overall this is an important bill and one that the Commission would support, albeit with what we think would be sensible additional safeguards.
Okay, thank you, Les, for that. And obviously the committee have had a number of conversations around fundamental issues within this legislation and the fact that it is an important piece of legislation, but there are concerns there that we've expressed from the outset around public interest, social well-being and definitions and safeguards. But I'm particularly interested in what you're saying today, because what I'm hearing is you're saying it's too wide. And I'm also very interested in relation to its compliance with European human rights legislation.
Yeah, and my colleagues may want to come in. In terms of public interest is a very widely drawn term, and I have some understanding of why you would want to draw it widely, in that you wouldn't want to circumscribe at what value you might be able to utilise for secondary data. So on the one hand, I can see by widely drawing it, you ensure you've got as a greater opportunity as possible to use secondary data for very useful societal purposes. On the other hand, and this is I think where we've come to on reflection, if you're going to have a term as widely drawn as in the public interest, and my understanding is that that's been used in England and Wales relatively sparingly for the purposes of data, then what you probably need are very strong safeguards to ensure that everybody is clear what we are talking about when we mean public interest, which is where I think the code of practice potentially can come in, because it can then start to say, here are factors that you should look at when you decide what is in the public interest, and what you need to take into account, and what is the balance that you need to ensure that you're making, so that people, I think, can be reassured. I think in the quote I gave, part of this is about people whose data is being used, who I know from brief discussions I've had, most people are comfortable about using their data for good, sensible societal purposes where they know what it is. But if those people are reassured that their data is going to be used for those kinds of sensible purposes, then I think that makes sense. And that's probably a better route than to narrow public interest and perhaps then not be able to take opportunities to use secondary data that everybody around this table would probably support.
But you suggest in your own submission on page paragraph 18 it is, that
we
you talk about public safety.
Yeah,
well, public interest with public safety.
Yeah, well, originally we had talked about using public safety on the basis of that would be a narrower than public interest, which is much more broad, but that therefore you're beginning to look at what it is that's beyond health and social care that you might utilise. I think on balance, I think we felt that, having reflected on that, that by if you could deal with this by way of safeguards and be much clearer and stronger safeguards through the code of practice, through what the role of the committee is, how it publishes, when it gives authorisations, on what basis, then I think I'd be more comfortable about retaining the public interest.
Is there an option, in your view, just to remove public interest and be very, very clear about the purpose of the bill, or clearer about the purpose of the bill?
Yes, that's an option. The downside of that would be that if there were other reasons you might want to use secondary data that go beyond health and social care that could be quite legitimate, you're then having to fall back on the kind of common law approach, which is clearly what this bill is designed to try and move away from. Again, my understanding on occasions is that if people take a cautious view of this, then if you have a survey that, for example, looks at the health data beyond Northern Ireland, then one of the issues about whether our secondary data would be utilised as part of a much bigger study, if we didn't have this bill, or if you were going to use it for beyond health and social care, then there might be some issues in that circumstance where we might not be part of a much wider survey. And I guess you'll hear from Rare Disease Partnership, which is a good example of where the numbers in Northern Ireland might be very small. You might want to be part of a much bigger study in other parts of the UK or for example.
And what about my initial part of the question around compliance with ECHR?
Well, I think on balance, providing the safeguards are clear and robust, so I think it would be worth strengthening those to make absolutely sure. And I think that the guidance should contain, the code of practice rather, should contain a very clear articulation of Article 8. I mean, Article 8 and your right to private life is a qualified right. In other words, if you're going to use somebody's personal data, it has to be in accordance with law, it has to be necessary in a democratic society, and then there are a number of safeguards around that. So I think if you make it clear that in giving authorisations, you must be mindful of your Article 8 rights. The bill, in its explanatory memorandum, is very clear about this. It does say this doesn't override, and neither should it, the Human Rights Act, nor data protection provisions. So I think there are ways that you could do that.
But as it stands, do you think it's complete?
I think, as it stands on balance, and we haven't kind of taken legal advice or we looked at this. We would have been interested in having a look at or getting a bit more detail about what legal advice was taken where it said it was compatible with Article 8. But it's a rather long-winded way of saying, on balance, we think it does comply with Article 8, providing those safeguards are followed through.
But on balance, providing the safeguards? Or?
Yes, I mean, we're taking it at face value that the Department will set up this committee, that the code of practice will be thorough and comprehensive and detailed. With those caveats, then I think, yes, it would meet Article 8.
Yeah, with those safeguards built in.
Yes, and I think part of your committee's perhaps role will be to ensure that those safeguards are as robust as possible.
But I think it also might be useful to get a view from the department as to their sense of it being compliant as it currently stands.
Yeah,
given the wide interpretation of processes like public interest.
Yes.
Or even further in the bill, the social wellbeing issue.
Yeah, I mean, one of the reasons we were very keen to see exactly what the publication of the authorisation, they've said they will produce regulations that set out how authorisations will be given and those will be published. But I think we'd like to see exactly what that means in practice.
Okay. David, did you want to comment on
just when we were looking at it, if you look at the Commission submission on paragraphs 15 and 16, we thought it was pretty clear where the language had come from the Department. So the language public interest is obviously derived from the EU directive. The EU directive talks about substantive public interest. And so is the Council of Ministers, from the Committee of Ministers from the Council of Europe, uses similar language. So the phrase public interest in and of itself isn't something strange in terms of the standards that the Commission would be looking at. The question that you have rightly raised is the extent to which, in the domestic law then, the subsequent protections are sufficient enough to meet the Article 8 test. But the language itself isn't something that is unheard of. It obviously comes from the EU directive.
Okay, but I think it goes back then to the conversation around the purpose of the legislation and the purpose of the bill, if you like, the intent.
Yes.
Of the bill is critical. Okay, there are a number of members. Alex first.
Yeah, thanks for your presentation. So would it be fair to say, in general, you support the bill, but there needs to be some changes? Would that be fair comment?
Yeah, it is. We can see the underlying purpose of the bill, which is to use to use the secondary data for legitimate purposes in terms of looking at kind of research issues about that will be useful for prevention of kind of diseases, what might be the underlying causes of ill health, etc. And I think we can accept that there may be, beyond health and social care, although perfectly legitimate reasons for using secondary data. What we are saying, though, is you have to be mindful of the use of that data, which can be identified for individuals in circumstances where people haven't given their consent, and you will. But this bill allows you to avoid the kind of scrutiny of the courts in general terms. Therefore, it must have clear, firm, robust safeguards. So, as long as those safeguards, and one of the things about this bill is it says much of those safeguards, the detail is going to be in regulations. It's not on the face of the bill. It says regulations may bring forth a variety of different forms of those safeguards, but we want to be sure that those safeguards are firm and robust. And if they are, then I think we're comfortable with this as a bill that makes public policy sense.
Okay, thank you. In terms of the committee, you touched on sort of the makeup of the committee you would like to see. Have you any thoughts about the size of it, or would you like to see more people from the health sector been on it, or people from a lay background more been on it, or what sort of breakdown do you think you would actually like to see?
I'm not sure I'd be prescriptive about kind of the background, but I think it would make immense sense to have a mixture of both lay and professional people. I think it would be very helpful if you had one or more people who've actually experiential, if you like, so people who've actually suffered kind of ill health and disabilities on that committee. I think there needs to be a recognition that, as I said earlier, that there are certain types of kinds of forms of ill health which are much more prevalent in one gender than another. So I think we need to be sure that the gender representation reflects some of those issues. Speaking as a middle-aged man in a grey suit, we could ensure that not everybody sitting around the table are all middle-aged men in grey suits. So there are good reasons for both cultural disability and gender as to why this could be a committee that should have that kind of appropriate balance.
Okay, finally, in terms of the code of practice, obviously you would like to see it set up as soon as possible and that it's all complied with. What type of sanctions would you like to see put in place if the code of practice was broken by anybody? Because we had it in the previous submission about penalties and stuff like that, and it's quite loose in what they're saying, isn't it?
Yeah, the
Level 5.
The bill actually does have provision for sanctions. I would have thought it strikes me that there are kind of a range of sanctions that would make sense, from the very serious breach in the top end, which is in the bill, to other ways. One of the reasons I think for us about having a code of practice that's strengthened by saying it must be adhered to is it moves away from an argument about, well, have you followed the code of practice? No, well, we only had to have due regard to it, which we did. We had to have regard to it. Well, having regard to a code of practice can presumably mean anything from one end of the spectrum, well, there's that code of practice, and that's as far as you take it seriously, to at another end of the spectrum where you really do take seriously the code of practice. Well, frankly, you avoid that ambiguity if you say you must comply with the code of practice. Now, you can still write a code of practice that allows you, in some cases, a genuine and well-ordered and well-sensible kind of discretion, but it then, at least it pushes you into having to have regard to it. In terms of what those sanctions might be that are beyond kind of the sharper end, I don't know, I'd have to go away and think about what would make proportionate sense. So they need to be proportionate to the breach, if you like, of the code of practice. And that includes very serious sanctions at the serious end to something that, frankly, is less serious but still significant. You want a range of sanctions.
Okay, thank you.
Sorry, just building on that.
Sure, yeah.
We did welcome that there was a maximum sanction and complied with guidance, but we did note that the bill also referred to other procedures, and we had recommended that the department could be asked to give an indication of what those were, because it wasn't very clear. I mean, whether they were administrative or employment or disciplinary, we weren't, so that's something that maybe the committee might want to ask the department.
The reason, part of the reason why we've asked for the code of practice in terms of the obligation to comply to be strengthened, the Commission has cited the case of Can v the UK, and the court had considered the issue of guidelines in the past, and it said that where it was neither legally binding nor publicly accessible, that this couldn't satisfy the accordance with the law requirement under Article 8, since Article 8 is the focus. So that's why we've come out so strongly in terms of must comply rather than have regard.
And Kieran next.
Yeah, Chair, thanks very much. Thanks very much for your presentation. My question is largely against the background of what the Chair had asked for in relation to the term public safety as an alternative to public interest. Is it sufficiently robust and understood in case law to fully capture all potential health benefits that arise from the authorised use of data in particular circumstances?
Yeah, well, I think I addressed that in my kind of in our kind of reflection, which was that hand on heart, if it was public safety, would that leave room for legitimate use of secondary data for other purposes outside of this bill? I think the answer is probably yes, it would, which is why I posited the alternative, which is that you retain public interest, but make sure then that the safeguards, including setting out what the public interest, what the factors are when you consider the public interest would be in practice. So yeah, I think the point you're making is legitimate. If you wanted to use secondary data for other kinds of planning purposes, transport or education with particular for people with particular needs or something else, would that fall within public safety and health and social care? Well, you might get into a debate about whether actually that falls within the bill or not. And so that's the problem, I think, of narrowing the definition. On the other hand, you don't want public interest to be used as a kind of code for anything that I decide is in the public interest. And that's where you want the kind of safeguards to make sure that it's a much more clearer articulation of what we mean by the public interest, as opposed to, well, my view of the public interest might be different from yours, Kieran, or Paul's, or anybody else's round the table.
And originally, when we were looking at the submission and Leitner's submission, we used the term public safety because it reflects the language in Article 8 of the Convention. So.
Yeah, okay. Right, that's fair enough. Thanks, Chair. Thank you.
Okay, Rosie, next.
Thanks for the presentations. I suppose I just want maybe to hear what your view is, and you have referred to it in your written material, about the use of the language may provide in a couple of places, may set up a committee, and where you have referred to it in a couple of places. What do you think about that? Because we've formed a view that it hasn't been put together strongly enough. Would you view it that way?
Well, what May does is it gives the department the discretion whether to do it or not. So in theory, and I've got no reason to doubt the department's bona fides that they intend to set up a committee, for example, but the legal position is quite clear. If you may set up a committee, then you equally may not, and therefore it's within your discretion. If you must, or use the must or shall, then you've no choice but to do it. I think in this case it would be inconceivable that the department would set this legislation in train and then not have any safeguards. But it puts it beyond doubt if you use the word must, and that's the advantage of.
Yeah, I agree, but it just makes me wonder then why didn't they say must? It's just hard to understand what the purpose of saying may, because it leaves an option.
I don't know what the thinking of the department. I'm not privy to the thinking of the department of that, but that's one to ask the department. I suspect it's kind of. It's speculation on my part, but it's not the first time that government departments and governments have given themselves kind of latitude in terms of just being cautious about those things. But it's clear that this will only, I think, provide genuine public confidence if there are proper safeguards. So in this context, I can't see the advantage of giving themselves discretion, because it seems to me that they have committed themselves to setting up a committee, and actually the sequencing of this is really important. I don't think you can implement this bill in practical terms without those safeguards being in place. So the code of practice, the committee should all be commencing in effect pretty much at the same time, so that you can ensure that any purposes for use of health and social care secondary data has got the kind of authorisation process in place, has the code of practice up and published, so that people understand what the safeguards are.
Yeah, that's it. It's just because it's about sensitive personal information, then it just needs to be as robust as it can be. In terms of clause 1, 2D, which has been referred to about making it an offence, would you think there's merit in saying that should be at the face of the bill rather than just by regulations, so that there should be a robust punitive measure that would be very clear, rather than left to regulation?
Yeah, but the sanction is on the face of the bill, at least up to level 5. I think 1.2d does say, in my recollection, what the, if you like, the maximum sanction would be.
Conviction
But
by
it's
a fine not exceeding level 5.
Yes.
Yeah, but its regulations may make provision, you know, I'm just saying it could be more robust.
It's probably, again, I've got no reason to doubt that there will be other sanctions, and it's the same argument that I think to put it beyond peradventure, if it said must, then it would clearly ensure that the department had no choice but to do it.
Yeah.
And it's the same argument, I think, that, you know, in terms of the other provisions about using, you know, the discretionary power as opposed to a mandatory power to do something.
Sure, okay, thanks.
Okay, thank you. Okay, can I just maybe just had one other question around the opt-out. We've had a discussion, I suppose, around opt-out and consent, just in relation to sharing secondary information, and maybe just, you touched on it, Les, but maybe just your views on that. And again, if there's any impact on human rights if opt-out isn't provided for, or consent, for example, isn't considered or is considered irrelevant. Are there views from a human rights perspective on that?
Well, the Article 8 issue would be this bill, as I understand, allows you to use the secondary data without having everybody's consent. So it gives you, it provides you with, if you like, greater safeguards than you would have in kind of common law. So you don't have to go into that kind of justification for common law purposes. But in terms of Article 8, if somebody then said, you have used my secondary data for illegitimate purposes, then the question, I guess, for Article 8 would be, they would look at, I guess, the individual facts of the case. They would look at it in terms then of the safeguards and what safeguards are there, and therefore, and the issue would be whether those safeguards were sufficiently robust, precisely defined in the circumstances of this case, bearing in mind that Article 8, while it, and the quote I gave from the Latvian case was a very good example why, you know, confidentiality of personal information is of fundamental importance, and if you're going to breach that right of privacy, you must have very clear and precise reasons in law, and they must meet a number of the kind of qualified rights. So I can't give you an answer of yes or no, but other than to say that clearly the Human Rights Act and convention rights still apply here. I'm not sure that you could have a provision that said whether an individual can opt out as opposed to a group and what the circumstances are. I'm not sure what provision would be in place. So the committee that kind of authorised data, for example, will they be given the kind of information that says, well, one person out of 300 here don't wish to participate in this, as opposed to 50 out of 300 or whatever that might be. I'm not sure what the mechanism is in terms of, you know, if you're not getting people's direct consent in the first place to use their secondary data. It's not an area I know enough about to know how that works. I think you've probably got other people this afternoon in terms of cancer registry, for example, who may be able to tell you what those practical ways of dealing with that are.
But it just, I mean, I suppose it seems to me that there's a lot riding on the safeguards.
Yes, I think that's a fair comment.
And I suppose in terms of even Article 8, you know, the other issue that we haven't really touched on has been this reference to social well-being. And in clause 11b, again, social well-being of people, including all forms of personal care and other practical assistance provided for individuals who, by reason of age, illness, disability, pregnancy, childbirth, dependence on alcohol or drugs, or any other similar circumstances. It seems to me that any other similar circumstances is hugely broad.
It's very, very widely defined. In my view, it would still need to be for some legitimate purpose. And if it came down to kind of a court having to look at this, I suspect they'd want to interrogate what that legitimate purpose is, albeit recognising that this is drafted in very, very broad circumstances. And you would have hoped that the kind of if this committee that provides the authorisations is doing its job properly, then they ought to be interrogating what is it that you want this data for, what is its purpose, what is the societal benefit, the public interest here, and takes account of the kind of factors that would include, presumably, just the fact that on the one hand you're using people's data and that people may be able to be recognised as a result of that, and the importance of that against what is the purpose that you're doing it for. And presumably part of your authorisation process should be saying very clearly, on balance, the potential good that comes from this justifies any of the potential issues around using secondary data that might arise.
There's
for
a
the
potential
individuals
as that stands that that's not human rights compliant, surely, if it's not defined, or any other similar circumstances.
Well, coming back to the Latvia case that Les mentioned earlier on, there was a violation there, not just because the law wasn't formulated with sufficient precision, but it didn't sufficiently clarify the scope of discretion conferred upon the authorities. So, in order, the law would need to be very clear.
So it wasn't defined.
It wasn't drafted with sufficient clarity to highlight the scope of discretion.
I mean, this is defined very broadly. The kind of legal issue would be, if it's defined as broadly as that, it would still then become A, the safeguards and how they work, and B, the proportionality of what it was that was being done. So you'd still, I think, in my view, have to go through some process of justify. You wouldn't be able to simply say, but it says other circumstances, so we can do what we want here. If the safeguards are robust, and if you can proportionally justify it, fine, but that's what you possibly would have to do.
But just finally, I mean,
Yeah, sure.
I think that in terms of if there was consideration to replacing, for example, public interest with public safety, you would also need to be very specific that that's public safety in terms of for health purposes, surely.
The difficulty, and this is where we were kind of reflecting on this, if you make it health and social care and public safety, well, if you define it as public safety and just take out from public interest, I don't know that it confines it to health and social care. There might be other public safety issues that you would be looking at. So I don't think it's confined to that. The more difficult issue, I suppose, would be the bill might fall foul of, if you wanted to use secondary data for, as I said earlier, education or perhaps transport or planning or some other purpose, and the question would be, is that public safety, is that health and social care? You then move into a kind of a much more difficult definitional. Now, it would require somebody to be unhappy with why you are using the secondary data in that way, but it does narrow, if you like, the potential use of secondary data. So you've got to weigh up that against the kind of public confidence there needs to be. And in my view, you can get that public confidence if the safeguards are clear, transparent, and robust.
Okay.
Just
Colonel,
one
yes.
point. I just want to clear that up, because are you saying that if there's enough around definition, enough around safeguards, and enough around a committee, that would be sufficient to allow no opt-out?
I think potentially, yes, that is what I'm saying.
But where does that fit into my right not to want to share that information?
Well, the whole purpose or rationale of this bill is to make it much more difficult for someone to take a kind of legal action. The common law duty was that you either have to get somebody's consent, in which case that's no issue, then you can opt out in common law terms, unless there is already a kind of statutory purpose that says you can override somebody's consent. And then you've got the second where you can override somebody's consent in common law terms. This is strengthening that. So the idea that you have with this bill that you'll have an absolute right to opt out, this bill will not allow somebody to say of themselves, I don't wish my data to be used, because this is about, as I understand it, is about using secondary data that doesn't involve going around to everybody that secondary data you want to use and say, can I have your permission? Because there wouldn't be any purpose to this bill if that's what you're already doing. You know, I don't know the kind of fine detail of how currently that's managed, but this bill is effectively saying there are some purposes where we can use secondary data where we are not going to go to every single person affected and say, do you mind if we use your data?
It also, I mean, what we don't know, and maybe the department can provide the answers, is the sorts of practical examples of where public interest, for example, might be used, and how secondary data could be then transferred between departments or between public authorities, for example. But if you think of examples at the minute where there's no opt-out clauses where secondary data would be used, think, for example, of religious belief of children in schools, and how the Department of Education would use that in terms of secondary data, including releasing it into the public domain. Now, obviously, Article 8 is engaged for the individuals whenever they are registered in schools or whatever, but the way that data eventually finds its way into the public domain for research purposes or whatever is in a way where the individuals can't be identified. It's clearly proportionate, subject to a legitimate aim. So there is examples already in public life where data is captured from an individual source, but the way that then is transferred out is perfectly proportionate.
And is that sufficiently covered in the legislation that you see it presented to us?
Well, there is potential, as it says, for it to be totally compatible with Article 8, but it's entirely subject to a lot of the things that are going to come forward in terms of the regulations, the safeguards, and the issues that we've addressed and discussed around the musts as opposed to the have regards, those sorts of things.
It's not satisfactory. I know kind of on balance, if you get the safeguards right and they are properly provided for, I think we are comfortable that this would be within Article 8. Now, if it was utilised in a way, somebody could make a terrible judgment call. Somebody could, the safeguards could turn out not to be as robust. You know, all kinds of things. But on balance, looking at it as it stands, if applied properly, if it was a committee that was rigorous in its approach, if the code of practice is comprehensive, you know, these are lots of ifs. But if all of that's in place, then I think we are comfortable with this, but we want to make sure that all of those things are in place. We think it'd be very helpful if the committee can ask the department the kind of questions that make sure that's the case, that people see the code of practice, have a chance to comment on it, that it addresses Article 8 issues within the code of practice, with all of those caveats. That's a yes, but it's a yes subject to all of those caveats.
The other thing which is extremely useful, as it said in the opening presentation, which is the fact that it's subject to affirmative resolution.
Yeah.
With the regulations coming forward, that's obviously an extra safeguard for yourselves in terms of the legislature.
Yeah, I'm tempted to say brevity and the Human Rights Commission are words you hear very often in the same sentence.
Okay, well look, can I thank all three of you for attending, and certainly it's been useful. We'll reflect on what you've presented today, and thank you for your time.
Yeah, thank you.
Okay, members, moving on to item 7. We have representatives from the Rare Disease Partnership, Fire and Rescue Service and Cancer Registry. We're also here today to give oral evidence in terms of the bill that's in front of us today, the Control of Data Processing Bill. The evidence submitted by these organisations is at page 101 to 124 of your meeting pack. You're very welcome. We have Amy Jane Knight, who's the Director of the Rare Disease Partnership, Dr. Anna Gavin, Director of Cancer Registry, and Mr. Dale Ashford, who's the Interim Fire Officer, Fire Search and Rescue. You're very welcome to committee. I'm going to invite yourselves to make your opening presentation. We'll open up to comments or questions.
Is there a particular order you would like us to go
No, not
in?
at all. You decide.
Okay, well,
Go ahead,
I'll
Anna.
start. Thank you. First of all, thank you very much for the opportunity to come and present to the committee. I'm going to talk about cancer, but actually it could easily reflect other diseases. You're probably all aware cancer is quite a burden in our community. We have 3,500 cancer deaths, and in 1994 the Department of Health invested and had foresight to set up a cancer registry. So we know not just what's the tip of the iceberg, but what's below the waterline. We know there are about 12,000 cases of cancer diagnosed each year. We know their survival. We know how many people are living with cancer. We know how their treatment has changed and how it has improved. And what I want to do is to take a fictional patient and just follow them through so that you could practically see how this bill would affect and how it would work. And this is what happens currently. So if we take a lady who's in her 50s and she discovers a lump and she has a biopsy and then she has surgery and then she has radiotherapy and she might have chemotherapy. So she interacts with health service maybe about 20 times in the period of that one cancer. You might say, well, we can use that data, and we do use that data, but why could we not do that anonymously? And so the problem is that if we did it anonymously, we wouldn't know whether that was 20 individual women who were coming in contact with the service or whether it was one woman coming 20 times. In addition, we wouldn't be able to link back to the screening service to see, did she have a mammogram? Did that fail? What was the quality of the mammography service or whatever screening service that she was in? We wouldn't be able to look at linking it with the deaths to see how long she survived. We wouldn't, without her postcode, be able to know whether she lived in a deprived area or an affluent area, whether the rate of disease was higher or lower in that area, or whether her survival was higher or lower depending on whether she was affluent or deprived. And maybe there would be an energetic MLA who would think that there were a cancer cluster in their area. If we didn't have the postcode, we wouldn't be able to answer those questions. If we didn't have information on all the cancers that are diagnosed, we also wouldn't be able to answer those questions. So the cancer registry and other disease registries need identifiable data for those reasons that I have outlined. But in addition, this lady her family may think that there is a family history of cancer here, and the information is needed also by the clinical genetic service. Now, the clinical genetic service may find the person may come and they say, my Aunt Molly, who lived in wherever, had a cancer. They don't come with a number, they don't come with any details, so that's why we need the actual identifiable data, the person's name, their address, their date of birth, for this type of information. That information is then anonymised for analysis, and these are some of the outputs that we produce, and I have left copies of some of these for you that are relevant, so you can have a look at the outputs that we produce. They're also available on our webpage. So you might say, well, what about consent? And consent, if we think about breast cancer, there are at least 1,200 ladies every year who are diagnosed with breast cancer. There's another over 1,000 with lung cancer. There are 12,000 in total. The opportunity to ask for that consent, to record it properly, to make sure that the person was actually giving consent whenever they're getting a very difficult diagnosis, that they understand what's been said, is not possible. So the numbers leave it that we can't have consent. There are cancer registries throughout the world, and they operate under legislation, and other disease registries, and what this law would do would be bring us into line with those registries. But cancer registries apply their own rules about confidentiality of information. We have a really secure environment for the data. We only there are only 20 staff who work in the cancer registry, and about 1/3 of them have access to the name data. I don't know the name data because I don't need it to do my job. So it's very restricted who has access to this identifiable data. And there's ethical approval. And once somebody needs the data for analysis, it's anonymised. If they need name data, they have to have ethical approval, they have to have lots of additional steps. The last speaker was questioned about opt-out. We actually, and registries have opt-out. So if somebody wants to opt out, they have that option. But nobody takes that option up. We have the support of patients in terms of the work that we do. Patients are very keen to see their data used. One of the problems that we have at the minute is that we have anonymised data gathered, but this anonymised data, we're not allowed to send it in an anonymised form to England so that it can be benchmarked, our services can be benchmarked, because we don't have a legislative framework here. So we really need this legislative framework to allow the work of the Cancer Registry to continue, and also to allow us to benchmark our findings and outcomes against other areas internationally with anonymised data. So I would really like to say that we would be very keen for this bill to succeed. Thank you.
Thank you. Anna, any of the rest of you want to comment at this point? Yeah.
Do you want me to comment, or do you want me to just do my opening
Go ahead,
statement?
yes, go ahead.
Okay, right. So I've written mine down and read it out so I don't forget, and I'm not as articulate as Anna, I have to say. So thank you for the opportunity to address the committee on the subject of the Health and Social Care Control of Data Processing Bill. In 2010, fire safety legislation in Northern Ireland changed, and a renewed emphasis was placed on risk assessment and on life risk rather than property risk. Consequently, there have been very few fire deaths in premises in Northern Ireland where there is a requirement for a statutory fire safety provision. We regulate commercial and industrial premises, and in conjunction with building control, we enforce legislation that has served the people of Northern Ireland well in terms of keeping them safe from fire. When people die excuse me, in an accidental fire in Northern Ireland, they tend to do so in their own homes. Over the past 5 years, there have been 50 accidental fire deaths, and 96% of these have happened in dwellings. The legislative position is such that we do not have enforcement capabilities within private dwellings. People who die in fires in Northern Ireland tend to share certain other characteristics. They tend to be older. Very often, they have existing medical conditions which may affect their mobility or their cognitive function. Another common theme is that they have lifestyle issues such as alcohol or drug abuse. Very often they are smokers and they commonly live alone. We also find that the more remotely they live from a fire station, the more likelihood there is that a fire will have serious consequences. And a characteristic that virtually all accidental fire death victims in Northern Ireland share is that they are almost without exception known to DHSSPS. With the recent trend towards more vulnerable people spending much more of their lives in their home environments, we have effectively shifted the risk from a highly regulated, fire-safe environment that we experience in a care facility to an unregulated and potentially unsafe environment that exists in people's homes. It's my belief that by working in partnership in a meaningful way, we could significantly reduce accidental fire deaths in Northern Ireland on our watch. Identifying people that have a combination of the risk factors I mentioned would allow us to identify who's most at risk and take meaningful steps to reduce that risk. This would allow us to transform the manner in which we carry out our prevention work. We need our endeavours to be intelligence-led, and we really need to concentrate our efforts and resources where the risk is highest. Working in this way would allow us to firstly, and most importantly, save more lives, but secondly, save money and operate much more effectively. There is much that we can do to reduce risk. We currently work with partners to identify people that are at risk, and where we do so, we've worked in conjunction with those partners to look at possibilities to reduce the risks. The whole arena of assistive technology in this area is one that is developing rapidly, and we have many examples of activities that we've carried out to help reduce those risks. Things like introduction of portable misting systems, which are effectively a portable sprinkler linked to a fire alarm system, fitting of cooker shut-off valves, which automatically close down a cooker when someone leaves the chip pan or the grill unattended, flame-retardant clothes and furnishings, guards and barriers to prevent access to heat and flame sources, fitting of smoke detectors, education and advice, and very often, most importantly, training of carers and family members. The current nature of our work is not ideal. It leads for the potential to us to miss the most vulnerable people simply because we don't know where they are. A systematic approach would allow us to properly prioritise our prevention work and provide a consistent professional service across Northern Ireland. My colleagues in England have the benefit of similar legislation. They have recently reached agreement with NHS GB to share Exeter, which is GP data, and a working group is currently developing protocols for the sharing, storing and processing of that information. I believe that in NIFRS we could refine and improve this approach, and I believe that we could process data in such a way that we limit to a bare minimum the amount of sensitive data that needs to be shared. And I'm perfectly content to give assurance that NIFRS will contribute to and comply with an approved code of practice to ensure that robust safeguards are in place. There's potential for wider benefits for the public of Northern Ireland, working in partnership with other agencies and groups, particularly in the context of community planning partnerships in the future. NAFRS will engage in the wider health and public safety agenda, and there's the potential for us to help in other areas. I would like to develop and improve on ongoing work in English Fire Services aimed at reducing pressure on hospital A&E departments by taking a more comprehensive approach to public safety in its widest sense. This community risk reduction approach would reflect national best practice for fire and rescue services, and it would be made much more effective by an intelligence-led approach. The public has a justifiable expectation that public services should work together to keep them safe. A recent Coroner's Regulation 28 letter following the death of a vulnerable lady in Berkshire required the Fire and Rescue Service and various agencies in Berkshire to enter into dialogue and share information in relation to vulnerable people. While I'm not aware of such a letter being written by a coroner in Northern Ireland, I have personal experience of incidents where I believe that risk could have been mitigated or eliminated had we had access to better intelligence. To summarise, NAFRS is dedicated to keeping the public of Northern Ireland safe, and I believe we can significantly reduce accidental fire deaths. We're duty-bound to do everything we can to make this a reality. I recognise the need for proper safeguards on people's privacy, and I believe that the enactment of the data sharing legislation will be a significant step towards making Northern Ireland a safer place. Thank you.
Amy?
Hi. Again, thank you very much for the opportunity to provide some oral evidence. I think the cornerstone of what we'd like to say is listed in Appendix 1 of the submission. So I'd just like to take the opportunity now to set the scene a little bit for the background and emphasise some of the key points. Northern Ireland Rare Disease Partnership's a unique partnership. It's a combination of individuals living with rare diseases, the voluntary and charity groups who represent them, academics, clinicians, a wide variety of individuals, and we span the breadth from the very rare conditions to the relatively well-known rare conditions. We're represented in the Northern Ireland Rare Disease Partnership, UK Rare Disease Partnerships and various European groups as well. And one thing that's emphasised very strongly is that we can't extrapolate what happens in Europe to Northern Ireland, nor can we use data derived from Northern Ireland, similar to what Anna was saying, to benchmark and share experiences across the UK. The definition of a rare disease in Europe is one that affects less than 2,000 people in the population. That might sound rare, but actually cumulatively, rare diseases are very common. It's believed in the UK that rare diseases affect approximately 1 in 17 individuals, and in some areas that actually is 1 in 12 individuals affected. More than 80% of rare diseases have a genetic contribution. One thing we're very keen to emphasise is that data use, sharing and governance are critical issues for rare diseases in particular. Within the rare disease community, we're keen to ensure that we derive the maximal use of data, and ideally through the secondary use of data. We are aware of substantial concerns around this issue, but we're confident that the benefits of this bill significantly outweigh any potential risks, and that the use of robust safeguards will ensure data integrity and protection for the benefit of patients. We believe this bill is critical to the effective delivery of a consistent UK rare disease strategy and the Northern Ireland Rare Disease Implementation Plan. We've held a number of open meetings and working groups and run numerous surveys in the past few years. And what we've demonstrated is that patients and families living with rare diseases recognise that because there's a very small number of individuals affected with their specific set of medical conditions, as much data as possible needs to be shared. We need to make best use of all of the data that exists to share that information with bona fide researchers worldwide, and the wider sharing would be anonymised, to help develop effective surveillance, prevention and treatment options for rare diseases. This legislation would enable us to contribute to national audits, to compare the care of patients with rare diseases in Northern Ireland with that delivered in the rest of the UK. We're keen to emphasise that collectively rare diseases represent a significant public health concern, and that we can't use strictly anonymised data for the secondary use of data, because we need a mechanism, as Anna explained, to link different diverse data sets together in Northern Ireland. Perhaps that's genetic services, perhaps that's social care data. And despite the inherent risk, again, because of the rarity that multiple medical conditions are going to be associated together with specific individuals in Northern Ireland, these individuals, these patients and their families are very keen to share their data for further research. In fact, they're seriously concerned that not sharing that data would be severely detrimental and limit the potential scientific and healthcare developments that would ultimately improve their quality of life. Through the discussions that I mentioned and the surveys, the Northern Ireland rare disease community are 100% positive and favourable behind the secondary use of data sharing. Our recent research has confirmed that patients in rare disease charities in Northern Ireland are frequently very frustrated at not being able to participate in wider initiatives due to the limitations we have on sharing information. In terms of the control of information of a relevant person, we particularly value the provision, and there's been lots of debate around, and we just heard earlier, about the phrase in the public interest, and we had suggested replacing that within the interests of improving health, with health being the wider interpretation of medical, psychological and social health. We're also very keen that it's not just limited to medical information. We'd be keen to see this bill apply and be helpful in the education, transport and, as we've just heard, fire service arena. There's multiple projects under discussion in Northern Ireland to improve the lives of individuals living with rare diseases. And this includes modernising services for improved diagnosis, development of an online information hub, and research to help deliver a person-centred service for rare diseases. A lot of what we'd like to see happen, a lot of what's happening in the rest of the UK, won't be possible unless this bill succeeds. For example, a serious concern with rare conditions is delayed diagnosis and indeed the identification in rare diseases. The current process of reaching a diagnosis for patients with rare disease is referred to as the diagnostic odyssey, and it can range from a year in the minority of cases up to 20 years, and for some patients they'll never get a diagnosis in their lifetime. If we can't share the medical information that currently exists, if we can't bring information from different sources together, we have no opportunity to improve that diagnosis, or severely limited opportunity to improve that diagnosis. Again, if we're looking at audits and comparing data with the rest of the UK, around a third patients in Northern Ireland wait between 1 and 5 years for an accurate diagnosis. More than 1 in 10 wait longer than 10 years for their diagnosis, and around half of all patients will receive at least one misdiagnosis. If we have a better way to bring information together and to share information, we're improving that diagnostic process. Sharing data for rare diseases, clinical characteristics and medical pathways from multiple individuals is required to progress research towards a better understanding of diseases and more effective treatments and cures. At present, we can't actually calculate the number of individuals in Northern Ireland who are affected by rare diseases, and we urgently need a rare disease registry in Northern Ireland, similar to something that functions like the cancer registry. Sharing data will help us count the number of affected individuals with particular conditions and clinical needs, which again may often overlap between conditions. So if one person is affected by 3 separate rare diseases, we'd like to know that information rather than counting it as 3 separate people. Sharing data will also help health and social care develop an effective plan for delivering optimised health care for individuals with rare diseases by helping it to identify who's going to need what resources when. And we believe that reliable information shared across a whole system approach will be of strategic benefit for Northern Ireland. Unless reliable information can be shared, then coordination and collaborative information-based actions and evidence-based medicine will not occur. The range of services across Northern Ireland, we believe, will be of lower quality, have less impact and produce poorer outcomes. We would like to stress that we think it's imperative that a collaborative approach is taken to the use of data through both health and social care systems. And we believe this legislation is urgently required. In terms of the committee to authorise proceeding of confidential information, we welcome the plan to promptly develop and publish a code of practice with regular revisions, and we would be happy to participate in any such committee. There has been significant debate about sharing medical data for research, and we would like to stress that we believe it's entirely possible to have appropriate safeguards in place where it would be clearly accountable, robust safeguards, and have a very transparent process to ensure this data is used effectively and stored safely. We're very keen that data is shared in carefully considered circumstances, but would stress that there must be flexibility in the bill so that relative bodies with appropriate expertise can inform evidence-based medicine. This includes health and social care teams, academic researchers who currently hold multiple registries. We believe the committee would need expertise in clinicians, ethicists, epidemiologists and patient representatives. Without this bill, we will be unable to conduct rare disease research projects in Northern Ireland and contribute to UK efforts that benefit medical and social care. Once again, we'd like to reiterate that this legislation is essential for patients and families living with rare diseases in particular. Thank you very much.
Thank you, all three of you, for your presentation. Just struck listening. I get the opportunities in terms of the importance of sharing data and that being done in a legislative framework. But I'm particularly interested in what happens now. I mean, have all three of your organisations applied for use of secondary data to date, and what happens? What happens now?
You go ahead, Chef.
Yeah.
Okay, so for 20 odd years now we have been doing this. The Cancer Registry was set up by the Department of Health. We are registered under the Data Protection Act. It's now funded through the Public Health Agency. It's located in Queen's University Belfast. We have ethical approval for the databases that we hold, and we have presented our methods of operation to the Privacy Advisory Committee, and they have commended us on our structures, our security, the way that we inform people about what's happening. So if somebody has a diagnosis of cancer, in their pack they will get a leaflet about the Cancer Registry. There are also posters about these available in GP surgeries, in hospitals, in various places. And just this year we produced a video which was about the Cancer Registry to let people know what actually was happening to their information and how it was used. So we have been doing this within the existing legal framework, which isn't really there, but within any ethical approval or whatever that we could do.
But the sharing of secondary data continues.
Yes, we use secondary data to provide information on cancer for research projects which are ethically approved, for monitoring services, and for producing. We have produced a vast number of reports and various outputs that are very useful to the health service. They are also useful to clinicians who are monitoring the care of their own patients, and they're useful to the Department of Health who are monitoring and planning the services for cancer patients in Northern Ireland.
So how will the legislation, I'm just being devil's advocate.
Okay, well the legislation will mean that I won't have to convince people that they're not actually breaking the law when maybe they are. That we will be able to work within a legislative framework, but more importantly, that the data that we gather in Northern Ireland will be available for audits and for peer review of our outcomes with England and other places. At the moment, that's one of the things that we can't do, is to compare how our process of care for lung cancer patients, for upper GI patients, for different patients, compare with the care that the similar patients get in England. Also, without this law, I think that we could be challenged and the Cancer Registry would cease to exist.
Okay, thank you. I'm going to bring Fergal because
Chair, and apologies, I'm being called away to another meeting. So, and thank you all for coming in. It kind of demonstrates the breadth of the demand on something like this. So, maybe I'll just kick off with a couple of quick points. You're saying you would welcome committee membership. We would need to be assured that the committee would be as robust as possible. Does a rare diseases participation in that committee represent a conflict of interest?
Say that again.
Would your presence on that committee represent a conflict of interest?
I don't know is the answer to that. I think it's important that the public voice is heard on that committee. It's particularly important that things are conveyed down in an appropriate manner. Were you thinking of anything in particular?
No, just in that, would your answer always be yes to assessing the data and not be as critical because of your stated aims? That's not a criticism, it's just merely a point I'd like to tell. Dale, thank you too for your presentation. Actually, this gets to the point of the individual data being available now and a much wider audience being aware of an individual's behaviour, their addictions,
conditions,
or conditions in general. And is that not exactly getting to what our major concerns are around the privacy issue.
I think that, and I've had a chat with people from NISR and others about how we could do this. I think actually, if we're clever, I think we still need sensitive data, and I need to know addresses of people so I can go to find the people that are vulnerable. But I think if we're clever, we can do this in such a way that you actually share the very minimum amount of information. For instance, I mentioned sort of a number of risk factors there. I don't need to know what risk factors you suffer from or what your conditions are. I just need to know that you have a combination of those risk factors and where you live. Because once I get there, I can take the steps that I need to take to keep you safe. So I think to me that there's something around the management and how we collate and how we share that information that will help protect people. My needs, will be different from the ladies either side of me, in that I probably need less detail. I really just need to know where the people are.
Can I just clarify?
Yep.
My understanding of the committee isn't that, so this bill is to enable data sharing. The committee's responsibility would be to say where and when the data would be shared. So from our perspective, the answer wouldn't always be yes. It's yes, in that we're strongly supportive of the bill to enable that facility to share data, not that data should always be shared.
Yeah, okay. All right, that's the point. Okay, and I'll just be excused.
Okay, thank you. Kieran?
Yeah, thanks, Chair, and thank you all for your presentation. I have a couple of questions to you, Anna, if you can help me. How important is this legislation for collaboration between Northern Ireland and other jurisdictions in relation to large-scale research? And how out of step do you think we here would be without balanced legislation as proposed?
Okay, so if we partake in any large cross-boundary research, generally what we do is we would have the data anonymised as far as possible. But sometimes you need to give broad categories of identifiable information, but not at the individual level. But one of the things are that the host places, so for example, we've run into this problem with England, that the people who would analyse the data, even though it's anonymised, are refusing to accept it from Northern Ireland because we don't have a legislative framework. So although the data have been collected and anonymised, and they're ready to be just put into the system, so we're having to think about do we analyse it then separately, and there is a risk then that in analysing it separately we don't do it the exact same way as they do, and so we're not part of a larger report where it's easier to see how we compare with other places. So that's a real difficulty that
so if we get this legislation through, that should overcome the problem.
That should overcome the problem, yeah.
Right, so sooner that's done, the better. Yeah. And what was the other one? How out of step do you think we are without balanced legislation as proposed?
Okay, so from the point of view of cancer registration, and in other countries also for wider disease registration, there are many, many countries that have a legislative framework that allows this to happen and allows people to provide data to registries without the fear that they're actually doing something wrong or that they're breaking the law, that they can do it within that legislative framework, but that they are secure in the knowledge that those data are held confidentially, that there are good mechanisms in place either with the security of the environment, the security of the processes, but also the committee that's mentioned, that committee actually has people on it who are quite strict about what, who can have access to what data and if it's the minimum that they need.
Okay.
Thank you.
Thanks very much, Chair. Thank you. Bruce.
Okay, just to clarify my way of finishing this part, I'm not picking up that there's any particular from your three organisations concerns around the definition of public interest, for example, that you don't see that from your organisation's point of view as being an obstacle or a risk even?
No. From FireService point of view, I don't see it as being a risk. I would say public safety, the earlier speaker talked about changing that maybe to public safety. I think for us that would probably feel like a better fit, to be fair, but I don't have any objection to public interest.
Okay. No, that's been clear. Sorry, Annie, were you?
Well, just to say that Amy's definition of health is actually a very good one. So it's not just the physical health, it's your physical, social and mental well-being. And I think any of these registries, there's no point having them. You have to do something with them and you have to do something to improve the public's health in the wider sense, or you have to improve services. We're not interested in setting up registers of disease or counting people just for the sake of it. There has to be a definite benefit for society from doing this, because there is a cost and there is the potential risks to privacy as well, and they have to be balanced with the outputs.
Okay. Okay, can I thank all three of you? Oh, sorry,
you.
Rosa, yes.
So just to clarify on that then, are you all sort of comfortable with in the public interest? You don't feel that's a very broad remit, rather than confine it to health and social care?
Well, I suppose from my point of view, what I would expect to be the case is that the committee that needs to make that decisions would need some very strong guidance in the form of the code of practice, and then to help them make those decisions about what public interest would look like. But other than that, yeah, I think public interest sounds okay to us.
I think we would be more concerned that the bill would go through under very tight and stringent criteria that would actually minimise the effectiveness of us having the bill. We're keen to ensure that it does apply to education and transport and other departments.
So you would be seeking that to be the case?
We would
broader than health and social care?
We would prefer it not just to be limited to the medical.
Right.
Okay. Yes.
Okay. There are, however, ways to link data without risking security, and there are ways, for example, where the census data is currently linked to other data sets. There's a NILS project which has linkage that cannot be unlinked to identify individuals, where you can actually do quite good research with linked data without risk at all to any identification of an individual.
Okay, thanks.
Okay, thank you. Thank you all for your
much.
time today, and
Thank you
certainly
very
we
much.
reflect on that.
Yeah. So I'm going to leave if the committee wish some outputs from the cancer registry,
yes.
which are here. Yeah.
Thank you for your time.
Thank you.
Okay, members, just by way of pulling this together from the last two presentations that we've had, I'm seeking agreement, members, that we would write to the department now on the back of the issues that we've heard today. I think firstly, just expressing our concern on the issues that are arising, but asking for that clarity. We have submitted the responses received. We have submitted those to the department, asking for clarity on those responses, and also asking, I think, particularly how the bill is compliant with Article 8 from the department's view. I think that would be appropriate. So, is an agreement to do that, members? Okay, thank you for that. Item 8 is the draft end of session report, which session from the 1st of September 14 to the 31st of August 15. Just advising members that it was agreed by the Chairperson's Liaison Group that end of session reports will cover that period, that they should be prepared and published on the website for all Assembly committees. Reports should provide information on the key activities and outputs of each committee in a range of areas, including primary legislation, subordinate legislation, inquiries, budget scrutiny, policy scrutiny, and informal meetings or events, and that we would outline the key priorities for the next session. So the reports would also provide information on committee expenditure for the period. There's a draft end of session report at page 126 of your meeting pack. I'm just asking members, we had touched on some of this last week, if members are comfortable, content with the end of session report, or if they wish to make any proposals or amendments. I think it's fairly accurate and straightforward. Are members in agreement then?
Agreed.
Okay. Item 9 is matters arising. Matters arising are page 135 to 141. There's 3 items. I just want to bring your attention to 2 of the items. Page 137 is the proposed departmental amendment to the Food Hygiene Bill. Again, raised last week, an issue had been identified with regard to clause 3.4, which has the potential to cause district councils operational difficulties in operating the scheme. The department proposes to address this issue through an amendment in further consideration stage. The proposed amendment, as we mentioned last week, is very technical in nature and doesn't really affect the policy. So are members content to note?
Great.
Agreed.
Item 9.3 on page 141 is a copy of the newspaper article on the data breach in England that Mr McKinney had referred to last week during the session on the data processing. The care data is a different system that's used in England. Its legal basis being the Health and Social Care Act 2012. It concerns the extraction of patient GP data to a central database and is combined with existing hospital records to support, for example, earlier diagnosis and disease monitoring. So the information can be made available in and outside of the NHS. This data is protected by a different set of safeguards and patients can indeed opt out. However, members may wish to bear this example in mind as we go forward considering the bill in terms of what can go wrong if the necessary processes or structures are not in place or not fit for purpose. So are members content to note the remaining matters arising?
Yeah, Chair, can I just raise 9.1? I would have to express deep disappointment on the response from the Minister on this. Those of us that visited that place in the Royal, I think we give a commitment to the people there that we would do what we could to certainly improve the environment in which they're working. If members can recall the staff that's working there, and they're in atrocious conditions, if anybody can remember, they were there. And the response is that, however, at present funding and suitable accommodation has not been identified. I think it's time they got their finger out and got, we know about funding crisis, but suitable accommodation for the people, the staff there that is working, doing tremendous work on behalf of her. And I think it seems to be almost hidden, because the figures that we got from the nurses and people that were there was staggering, to say the least. And the public doesn't seem to be aware of that. And I think we should be shouting from high heaven to get something done with that as soon as possible.
Yeah. Can I just agree with you completely? There was no doubt of the hugely significant role that is played by the staff there on both services. And I think it really highlights, if you like, the flawed commissioning process that we have when we have two services that are commissioned separately. And I also think it highlights the fact that the gap, in the sense that we don't have the commissioning plan complete yet for 15-16. So, I mean, I have no difficulty with the members' comments and writing back to the department in relation to this to highlight the vital work that takes place, and to also request that the commissioning plan is brought forward with a degree of urgency. Indeed. And that we see a very clear commissioning of services for those two vital services that exist there.
Yeah,
okay.
I think that's...
Thank you for raising that. Thanks. Okay, members, 8 items of correspondence, page 143 to 355. Are members content to note?
Yep.
Item 11 is any other business. Do members have any other business? 12, date and time and place of next meeting, 23rd of September at 2 p.m. in the Senate chamber. Thank you for your time.
The Northern Ireland Assembly, Committee Room 29.